All right, guys, we're going to do just another quick lecture here over the nervous system and special senses. Okay, so let me go ahead and share my screen. I'm going to go ahead and kind of plow through this real quick. We will review this briefly in class tomorrow as well. But let's go ahead and just kind of zip through it. All right. Okay, here we go. So the nervous system and special senses. Clearly, this is going to be an extremely brief treatment of these systems because obviously they're very complex. So okay, excuse me, nervous system. Obviously, as we know, right, the nervous system is obviously composed of the brain, spinal cord, peripheral nerves, and special sense organs. Clearly, we have two divisions. We have the CNS, of the central nervous system, which is composed of the brain and spinal cord, and then the peripheral nerves, which includes, pardon me, all of the nerves coming off of the brain and spinal cord, cranial nerves, and the spinal nerves as well, right? So I don't have a picture of this in this PowerPoint because I think that would just be too much, but there are anatomic locations where we see obviously peripheral nerves are rising from plexuses, right? And so we actually have these anatomically. We have the cervical plexus, which obviously is formed from cervical nerve roots C1 through C4. Then we have the brachial plexus, which is cervical nerve root C5 through the first thoracic nerve root, so C5 through T1. And then we have the lumbosacral plexus from L2 to S1. Sorry, guys. So use the term when we talk about the nervous system. So we're going to kind of use the term interchangeably. So we have the somatic nervous system, which really refers to the system that's under conscious control, right? The musculoskeletal system generally is what we're speaking about when we talk about the somatic nervous system. And then we have the autonomic nervous system. Okay, so the somatic nervous system is obviously chiefly responsible for sensation and movement, right? So innervation of skin, fascia, right, and muscles. Okay, that's generally what we're concerned about. So not uncommon to not uncommon to see that often when we talk about the somatic nervous system, and at times when we talk about the autonomic nervous system as well, we will attempt to kind of describe the anatomical location of these structures by using the term level, right? And generally that is a reference to the spinal nerve or the spinal nerve root from which that level arises, right? And so, so clearly at each level, okay, we have essentially a portion of that nerve that innervates very often some skin or fascia, and that is referred to as a dermatome. If you remember, obviously, tome is an object used to cut. Derma, right? Dermo is the word root for skin. So that is an area of skin that is innervated, right, by a nerve root. Okay. Conversely, we have a myotome, which describes the muscular innervation according to a spinal nerve root. And we'll talk more about that tomorrow during our review in class. So with the autonomic nervous system, generally what we are concerned about is essentially the innervation, not only of smooth muscle, of viscera, right, and cardiac muscle, obviously, as well, adipose tissue and glands. So the autonomic nervous system actually can be further divided actually into both sympathetic and parasympathetic divisions. So when we think of sympathetic divisions, obviously we want to think of things being upregulated, right? Parasympathetic, meaning that things are essentially being kind of brought back towards baseline or downregulated. Now, there is actually an exception to this. Within the abdominal viscera, generally speaking, the more parasympathetic activity that you have, you will actually have increased smooth muscle activity within the abdominal viscera as well. And obviously, as we talked about in class last week, the more sympathetic activity that you have, the abdominal viscera are downregulated, which is why you don't necessarily realize that you have to go to the bathroom while you're working out. It typically, you typically will feel that after you've completed your workout, whatever it is that you're doing, right? Okay. Obviously, the basic structure of a nerve, right? So we have our cell body, right? Our dendrites, and then our axon. And I know that all of us are aware of the fact that we have both myelinated and unmyelinated axons. Clearly, nerve impulses that travel along myelinated axons travel at a higher speed because they have a saltatory response and travel along the node of Ranvier, right? So we know that about those nerve impulses. Okay. What about generally speaking, what about the interneurons that exist in the brain and spinal cord? So on a very basic level, we have both afferent and efferent neurons. Generally speaking, the way that this works is we pick some sort of sensation and or stimulus out of the environment. And that stimulus, creates an action potential that travels up through an afferent nerve, okay, to the spinal cord itself, and then connects with an inner neuron in the spinal cord, and then actually exits the spinal cord via the efferent nerve back towards the effector. In the case of a reflex, would be a muscle, right? And so that's a very basic kind of schema, right, for the nervous system, between the afferent and efferent neurons, not only within a reflex arc, but with just generally within the function of the nervous system itself. Okay. What about the brain, though? Obviously, the brain itself is actually referred to as the cerebrum. However, there are obviously different parts, different lobes of the brain that are actually further broken down. So we can obviously see the frontal lobe, okay, and we have the precentral and postcentral gyri, okay. And then dividing those two is obviously the central sulcus, right? So then we have the parietal occipital sulcus, right? So we have the parietal lobe, and then we also have the occipital lobe here in the back. What's actually not labeled in this picture is actually the cerebellum and the midbrain. I always kind of like to think of this as kind of like a boxing glove. And you guys can't see my thumb, but you have the temporal lobe actually as the thumb on the side of the boxing glove, right? And then obviously you have the frontal lobe and parietal lobe as well. But as I mentioned, not pictured or not labeled on this picture is actually the cerebellum and the midbrain and also the pons. So, okay, moving on to the high, guys. I know that we're kind of rushing through this, but so generally speaking, the eye has three layers, right? There's a fibrous layer, which is composed of the cornea and the sclera. So the cornea is right. The white portion of the eye, a little smaller, so definitely something that you'll see in people that have this. Okay, so the largest layer that we have here, excuse me, is the vascular layer. Okay, and that actually consists of the iris, the ciliary body, and the choroid, and is actually partially the pupil actually is surrounded by smooth muscle that actually contracts and expands in relation to the light, right? So for any of you, particularly when you're in school, learning how to do a cranial nerve exam, you will definitely learn how to do the pupillary reflex. And you will actually see this at work in a lot of your patients, okay? Then obviously the innermost layer is the retina, where images are not only obviously projected, but also where eye movement actually combines with the retina to actually kind of prevent, right, any visual echoes that kind of helps keep you from seeing double or seeing multiple images. So the physiology of the retina is actually extremely complex. Okay. Is that the eye actually also has accessory organs, right? So obviously, as all of us look around every day and we move our eyes left to right, up and down, okay, we're actually using our ocular musculature. So we have obviously superior and inferior ocular muscles, and then the medial and lateral, obviously, ocular muscles. One thing that you'll often see, particularly a lot of my athletic training students, to talk about this in the event that someone has an orbital blowout fracture, where they're due to some sort of trauma. One of the dangers that we often see with this is that they'll actually have crackling of one of the rectus muscles, right? And what will often occur there is that the muscle will become entrapped, and they will actually be unable to move the eye in the direction, in the opposite direction of the muscle that's actually entrapped. So it's actually it's something to always check for, particularly in the event of trauma to the orbit or eye, orbit or the eye itself. Clearly, we have the lacrimal glands. Okay, this is actually obviously helps move the eye. We have the conducts and the lacrimal glands, obviously. Obviously at the nose, and then obviously superiorly and laterally as well. These help to provide moisture to the eye. Okay. Whoops, I did not mean to superimpose this picture, guys. I apologize for that. But we look at the anatomy of the ear, okay, moving on to the ear. Okay, so we have the external, right, middle, and inner ear. So clearly the external ear is made up of the auricle, the pinna, right, and the external auditory meatus leading into the external auditory canal. Ultimately, particularly with or an external ear infection, there are times where ear infections can actually become so bad that the external auditory meatus actually closes. And so you will definitely see that if you practice long enough. So clearly, right, we have the external auditory canal. We get into the middle ear here. Obviously, within the ear, we have the malleus, the incus, and the stapes. These actually help us and can particularly off of the oval window, right, in the tympanic membrane, right, help us conduct sound. Obviously, for auditory processing. But one extremely important actually area of the ear is actually the inner ear, right? And this is actually also where we actually regulate our balance, right? So the inner ear is actually composed of the cochlea, the utricle and sacral, and then obviously the semicircular canals. So as we can see here, right, we actually have these otoliths that are actually contained within, this otolith, right? Sometimes trauma, right, and or with age, as the otolith, sometimes what will happen is they will actually break away from the otolithic membrane, and they will actually find their way out of the and make their way into this canal. When that happens, patients will often develop dizziness and can develop a condition, positional paralysis, right? Can be extremely developing that experience this and can actually also be right? So extremely important not to forget about the interview and know that obviously that this is extremely important in regulating balance, but also know how to assess and treat this. Okay. And you can also see obviously that as we change positions, these otoliths actually kind of shift and change positions within, right, the otolithic membrane. And that actually is what helps us kind of maintain not only our proprioception, but our balance when we're moving dynamically. So we've got a whole list of words here for you guys, obviously. So cerebellum, okay, cerebello, which is the root word for cerebellum, cerebrum, duro, okay, referring to the dura matter, or the covering around the brain spinal cord. Okay, encephalo, meaning brain. Okay, ganglio or gangliano, okay, ganglion. you know, and also obviously a really important one that you guys are going to hear a lot, but that you guys are going to hear a lot, radiculo or rhizo, meaning nerve root. So someone who has radiculopathy actually has a disease of the nerve root. Okay. Another big one, okay, is esthesio, okay, which means with numbness and tingling is going to be esthesia, right? Right. So clearly keeping in mind that the nervous system actually also obviously contains the, you know, also affects how we function psychologically. Mento or freno, right? Or psycho are all word that excuse me, that mean mind. So obviously, okay, phaso, speech, okay, polio, gray matter, and then another one, iatro, meaning physician. Okay, a couple prefixes, pre meaning before, and then tetra meaning four. Okay. Also quad, right? So someone who is quadriplegic has paralysis of all four limbs, right? And then we've got some suffixes here. Okay, so iatrist is a specialist. Okay. Also, we obviously use the suffix ologist as well to refer to this. Okay. Iatry is treatment or specialty. This is a suffix that refers to seizure. Had a seizure. In the period after the seizure has stopped, they are said to be in the post-ictal phase, right? Or the phase after the seizure itself. So they're post-ictal. Okay. And so, and then paresis obviously is a suffix for paralysis. So if they have hemiparesis, right, they might have, you know, paralysis of one half of their body. We often see that in stroke patients. They have hemiparesis of either one side or the other, depending on the side of the brain infarct at the time of the stroke. Okay. So some more special senses here, some more kind of word roots to learn. Blepharo, eyelid, okay, conjunctivo, pertaining to the conjunctive of the eye. So we have conjunctivitis, which is essentially inflammation of the conjunctiva, which typically manifests itself in kind of matting and crustiness of the eyelid, particularly in both viral and bacterial versions of conjunctivitis. Right, we have coro or chorio, okay, or pupillo, pertaining to the pupil. Okay, corneo. Okay, if we have a corneal abrasion, we have an abrasion to the cornea. Excuse me. So lacrimal, pertaining to the tear duct. Okay. Oculo or ophthalmo, optovision. Retino, pertaining to the retina. So for those of you that are athletic training students, or those of you that are going to go to PA school, one thing that you will learn to do and you will probably become very good at is actually a retinoscopic, or also referred to as a fundoscopic exam with your otoscope. So it's a term to be familiar with. Okay, so obviously audio you know, refers to hearing. RO or odo refers to ear. Okay. Mastoido, okay, that's pertaining to the mastoid bone right behind the ear. Okay, a complication of severe infection that goes untreated is mastoiditis, which is inflammation of the mastoid bone, which is where kind of the sternocleidomastoid actually originates up here at the mastoid process, right? So those are all terms to know, right? And some more roots here. Obviously, cryo means cold. Diplo, double. If someone has diplopia, they've got double vision. Okay. If they are photophobic, they're light sensitive or afraid of light. They may kind of, you know, kind of shy away from light if something is very bright. Okay. And then tono being the root for pressure. So more words to know here and be familiar with. Okay, guys. Once again, you know, sorry this was so brief. We'll review this in class tomorrow as well. But I just wanted to post this for you guys.